Okay, just gonna pan the room, my tools. Okay, hello, my name is Priya Alexander. I'm a PA student, and today I'm going to be performing a respiratory, CV, and abdominal exam. At this point, I would wash my hands with soap and water for 20 seconds. Okay, so the patient seems healthy and no apparent signs of distress. So I'm going to have you take your shirt off for this portion of the exam. First, I'm going to be inspecting the anterior and posterior chest walls. I'm going to be looking for symmetry, contour, AP diameter, and also just looking at the nail beds for any cyanosis, looking at the lips for cyanosis or discoloration, and there's none present. Now I'm going to be looking at chest expansion. I'm going to have you sit over there. I'm going to be placing my hands at T10. I'm going to be clasping a little bit of skin together and then having the patient take a big deep breath. Okay, so the chest expands symmetrically. Now I'm going to have the patient grab his shoulders like you're hugging yourself, and I'm going to be palpating the posterior wall for any masses, crepitus, deformities, tenderness, and there's none present. Now I'm going to be examining tactile fremitus, so when you feel my hands on you, just say 99.
99, 99, 99, 99.
Okay, so tactile fremitus is equal in all fields. Now I'm going to be examining diaphragmatic excursion. This would be done bilaterally, but we're just going to do it on one side. I'm going to percuss downward until I hear an area of dullness, which is about here. I'm going to have the patient take a big deep breath in and hold it. Okay, so this is my starting point. Go ahead, release. And now I'm going to have you take a big deep breath in and then expire it the whole way, okay? Expire. Okay, so diaphragmatic excursion is about 4 centimeters. After this, I'm going to be percussing the 7 paired lung areas. I'm going to be striking with my pleximeter finger and going in a ladder pattern. So I'm going to be pressing down with the pleximeter finger and striking with my middle finger. So. Okay, so there's no dullness to percussion in any of the areas. Now I'm going to be examining CVA tenderness. So did that hurt, or is there?
No.
So there's no CVA tenderness noted bilaterally. Now I'm going to be auscultating those 7 paired areas, instructing my patient to breathe in through an open mouth, and I'm going to be listening to a full respiratory cycle when I place my scope. Okay, so the breath sounds are vesicular and symmetrical, and there is no adventitious breath sounds heard. Now I'm going to be examining for lymph nodes. This would be done bilaterally, but I'm doing it just on one side. I'm going to have the patient put his hand on my shoulder, and I'm just going to be palpating the anterior lymph nodes, central, which is kind of down the mid-axillary line, posterior, and lateral, which is kind of up the arm. And there's no lymphadenopathy noted. Now I'm going to be having the patient lie supine on his back. I'm going to be doing a quick inspection, and I'm just going to be palpating the anterior chest wall for any deformities, masses, tenderness, crepitus. There is none present. Now I'm going to be doing tactile fremitus again. Have the patient say 99 when I place my hands.
99, 99, 99, 99.
Okay, so tactile fremitus is equal in all fields. Now I'm going to be percussing the 6 paired lung areas. I'm going to be, again, pushing down my pleximeter finger. So there's no dullness to percussion in any of the areas. I'm going to be auscultating those same areas using my bell above the clavicles and then switching to my diaphragm for the other ones. Again, breathe in through an open mouth, and I'm going to listen to a full respiratory cycle. So, okay. Okay, so breath sounds are vesicular and symmetrical with no adventitious breath sounds heard. If there was adventitious sounds heard, I would perform a special test. I'm going to be performing bronchophony. So I'm going to have the patient sit up. I'm going to be listening in this way. I'm going to be listening in 2 paired areas, and again, using my diaphragm. Okay, and I'm just going to have you say 99 when I place my scope, okay?
99. 99, 99, 99.
Okay, so it was very muffled. Bronchophony is negative. Now I'm going to be moving on to the cardiovascular portion of the exam. First, I'm going to be listening for carotid bruits. I'm going to instruct the patient to breathe in and hold your breath. So just hold your breath. And I'm going to be doing this bilaterally. No carotid bruits were heard on either side. Now I'm going to be listening to the 4 heart valves and Erb's point. I'm going to be using my diaphragm for this. So the second right intercostal space, aortic valve. Second left intercostal space, pulmonic valve. Third left intercostal space, Erb's point. 5th intercostal space along the sternal border, which is the tricuspid valve. And the 5th intercostal space on the left side along the midclavicular line, and that's the mitral valve. And now I'm going to be flipping to my bell and doing the same thing backwards. So this is the mitral valve, tricuspid valve, Erb's point, pulmonic valve, and the aortic valve. Okay, so that all sounds good. Now I'm going to be examining for the physiological split of S2. I'm going to instruct the patient to hold his breath again. I'm going to be placing my diaphragm at Erb's point. So take a big deep breath in. So at this point, I'd be listening for the physiological split of S2, which I hear, okay? Now I'm going to be examining aortic regurgitation. I'm going to instruct the patient to sit up, lean forward, and hold an expired breath. So breathe in and breathe out and hold the expired breath. Again, placing my diaphragm on Erb's point. So sit up, lean forward, lean forward. Okay. So there's no murmur of aortic regurgitation present. Now I'm going to be placing my diaphragm at Erb's point again, and I'm going to have the patient valsalva or pop his ears. So I'm going to be just listening. Go ahead, pop your ears. Okay, so there's no murmur when the patient valsalvas, which is good. Now I'm going to be moving on to the next portion of CV. So I'm going to have the patient lie supine. First thing I'm going to be doing is measuring JVP. I'm going to turn his head to the left. Place my ruler at the sternal angle, or sternal of Louis. I'm going to be finding the highest point of oscillation with a straight edge and measuring. Okay, So the JVP is visible at 2 centimeters above the sternal angle when the patient is at a 30 to 45 degree angle. Next, I'm going to be inspecting the precordium, and I'm going to be palpating the precordium. So I'm just inspecting for any heaves, and I'm also going to be locating the PMI, which is right here. Just going to be palpating for any heaves, lifts, or thrills, and there's none present. And the PMI is non-displaced, which is good. Now I'm going to be auscultating the same areas that I did before. Again, using my diaphragm. Second right intercostal space aortic valve. Second left intercostal space pulmonic valve. Third intercostal space on the left Erb's point. Tricuspid valve. Fifth intercostal space on the left along the sternal border. And mitral valve, which is the fifth intercostal space on the left along the midclavicular line. Again, switching my diaphragm to the bell. So going backwards, mitral valve, tricuspid valve, Erb's point, pulmonic valve, aortic valve. So everything seems good there. I'm going to have the patient go in a left lateral cubitus position. So I'm going to have you lie on your left side. I'm going to be placing the bell of my stethoscope on his mitral region, and I'm listening for gallops, which is S3 and S4. So I'm just going to be placing my stethoscope and listening. So there was no gallops heard, S3 or S4. You can turn back. So the rate and rhythm are regular without any murmurs, gallops, or rubs. The rate and rhythm are regular without any murmurs, gallops, or rubs. Yeah, correct. Okay, so now I'm going to be palpating the pulses. I'm going to start at the carotid pulse. So listening for carotid pulse, brachial pulse, radial. I would do the femoral, popliteal. Lift your legs up. The posterior tibialis, which is behind the medial malleolus. The dorsalis pedis. Go ahead, flex your big foot, your toe. Flex it. Okay, so listening for the, palpating for the dorsalis pedis, and that's lateral to the extensor, so that's all good. Now I'm going to be examining the nail beds for any clubbing, cyanosis, and I'm also going to be looking for capillary refill, so making sure it's less than 2 seconds, which it is. That's all good. Now I'm going to be palpating the legs, and I'm going to be looking for edema, viscosities, hair distribution. It all looks good. I'm going to be feeling the temperature with the back of my hands, and that all feels good as well. And there's no lesions, scarring. Okay, so that's the end of the CV portion. Now we're going to be moving on to the abdominal portion. The patient is lying supine on his back. His hands are at his side. His arms are laying next to him. And then I'm going to have you bend your knees for this portion of the exam. And I would expose him from xiphoid to suprapubic, but he already has his shirt off, so that's fine. So first I'm just going to be inspecting the abdomen. I'm going to be looking for symmetry, contour. It's a flat abdomen. There's no scarring, striations, or lesions, which is good. Now I'm going to be listening for bowel sounds. I'm going to be listening in the 4 quadrants in 3 regions. So the right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant, epigastric region, umbilical, and suprapubic. So the bowel sounds are present. Now we're going to be listening for bruits. So I'm going to be using the bell portion of my stethoscope. I'm going to place my stethoscope on the abdominal aorta, right renal, left renal, right iliac, left iliac. I would do femoral. So there's no bruits noted. And if I were to look at the femoral, I would look at the lymph nodes, the inguinal lymph nodes, and there would be no lymphadenopathy noted. Now I'm going to be percussing. So I'm going to be percussing the 4 quadrants and 3 regions. So I'm percussing for tympani and dullness. Those are the 4 quadrants. Now epigastric, umbilical, suprapubic. So that all sounds good. Now I'm going to be percussing the liver. So I'm going to be starting at a point of resonance. So up here is resonant until I find an area of dullness, which is about here. I'm going to make a mental note. Then I'm going to percuss up, downwards to upwards from an area of tympani until I hear dullness again, which is about right here. And then I'm going to measure. So the liver span is about 7 centimeters on the midclavicular line, which is all normal. Now I'm going to be percussing the spleen. I'm going to have the patient, so I'm looking at the left anterior axillary line around the 6th intercostal space. I'm just going to be percussing, and it's tympanic right now. So I'm going to have the patient breathe in, and it stays tympanic. You can release. It stays tympanic, and there was no dullness when I percuss. So that is good because there's no splenomegaly noted. Now I'm going to be palpating. So I'm going to be palpating the 4 quadrants, the right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant, and the 3 regions, epigastric, umbilical, suprapubic. There's no masses, tenderness, guarding, or rigidity present. Now I'm going to be deeply palpating, so I'm going to go a little bit deeper, again looking at the 4 quadrants through regions. There's no masses, tenderness, guarding, or rigidity noticed. Now I'm going to be examining rebound tenderness. I'm going to be palpating in the right lower quadrant, kind of hard. Have the patient take a deep, I'm going to be palpating hard, and then I'm just going to be releasing. And did that hurt? Or did you feel any pain?
No.
So there's no rebound tenderness noted when I took my hand off. Now I'm going to be palpating for the abdominal aorta. So I'm just going to find it. I'm going to place both sides of my hands around the abdominal aorta, and then I'm going to measure it. So it's about 2 centimeters, and there's no lateral pulsation or expansion. So the abdominal aorta is 2 centimeters without lateral expansion or pulsation. So next I'm going to be palpating the liver. So I'm going to find the liver, which is on the midclavicular line. I'm going to have the patient breathe in, okay, and then breathe out. Okay, so the liver is non-palpable and non-tender. I'm going to be having the patient lie on his right side. All right, I'm going to be palpating the spleen. So again, kind of holding his back and then going kind of under the ribs. Go ahead, take a big deep breath, and then release. So the spleen is non-palpable and non-tender as well. You can roll back. At this point, I would be doing the abdominal reflex. So I'm just going to be striking this around the umbilicus. And there's no abdominal reflex present, which is okay. It's a normal finding. At this point, I would do the genital, rectal, and hernia exams. Now I'm going to be doing the 2 special tests that we need to do. First, I'm going to be doing Murphy's test. So this is testing for cholecystitis. I'm going to be palpating in the right upper quadrant, having the patient take a big deep breath in and out. So the patient was able to breathe in and out without pain or grimacing, which is a negative sign for Murphy's test, which is good. And then lastly, I'm going to be doing a heel tap. So I'm going to have the patient stick out his leg, and I'm just going to be striking his heel. Do you feel any pain in your abdomen?
No.
No? So that's a negative test for the heel tap. So that's like you wouldn't have peritonitis or appendicitis. And yeah, that's the end of it.